Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our weekly webinar series on the medical and public health considerations of COVID-19. Today we have two very interesting and timely presentations. The first one and the main presentation about prolonged recovery from COVID-19 diagnostic and therapeutic challenges. And then we'll have a physician's perspective of living with long COVID. Next slide. I'd like to thank our webinar series partners for helping to disseminate the information regarding the webinar series to a wide audience of registrants. Very much appreciate working with them. Next slide. This webinar will be recorded and put up on our website in approximately 48 hours. You can also find our previous webinars that are available on demand. And the URL, as you can see, is acmt.net/COVID-19 web. Next slide. We also have a series of FAQs about a variety of our different prior webinars, and these can also be accessed on our website. Next slide. And there'll be a Q&A at the end of the webinar. This is often one of the highlights with lots of very interesting questions, and we'll usually leave 15 or 20 minutes for the questions. So as you think of questions, please put them into the Q&A box, and we'll try to get to as many questions as possible toward the end of the presentation. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology and president of the Middle Eastern and North Africa Clinical Toxicology Association and associate professor of emergency medicine at Emory University School of Medicine. Next slide. It's my honor to introduce our guest moderator today. Dr. Kirk Kumston is the president of the American Academy of Clinical Toxicology, one of our societies that helps to promote this webinar series. He's the medical director of the Virginia Poison Center and a professor in the Division of Clinical Toxicology in the Department of Emergency Medicine at the Virginia Commonwealth University School of Medicine. Dr. Kumston will be helping out with the moderation of the Q&A. We really appreciate his participation today. Next slide. At this point, I'd like to turn it over to Dr. Kazi to introduce our two speakers today.
Thank you, Dr. Wax. We've been wanting to bring to you this topic for several months. Dr. Wax and I and our planning committee, we've been, just looking at the schedule, and we're very fortunate to meet Dr. Michael Sagg from the University of Alabama at Birmingham through common colleagues. And as some of you may know, I've spent some time in Birmingham between 2005 and 2008. Dr. Michael Sagg has certainly been involved in the response to COVID, from the medical care to the vaccine, campaign right now, but also has been involved in this aspect of this pandemic. So it's really going to be a pleasure to listen to his comments and discussion about this prolonged recovery from COVID-19. Dr. Sagg is currently the director of UAB Center for AIDS Research, an associate dean for global health at UAB School of Medicine, and a professor in the Department of Medicine and the Division of Infectious Diseases. He will also converse after his presentation with our second speaker, who's a colleague of mine. At Emory University, we've been in general fortunate during this pandemic. We practice at Grady Memorial Hospital, but early on, Dr. Siegelman was infected with the virus and really had a lot of experiences to share with others, including in the Journal of the American Medical Association in November, where he described his experience living with long COVID. And actually, he's still, recovering from this illness, and will be candid enough to share with us some of his challenges, as well as some of the additional investigations he had to undergo and therapies. So I really look forward to Dr. Siegelman's comments. Dr. Siegelman is an associate professor in the Department of Emergency Medicine at Emory University School of Medicine, and he practices clinically at Grady Memorial Hospital, same place where I practice as well. With that, I would like to start with Dr. Sagg for his presentation. Thank you.
Well, thank you very much. And it's a real pleasure to be with everybody today. This is such a new disease. I mean, if you think about COVID itself, it's really only been around in the United States for about a year. But yet we are learning as we go. And one of the most devastating sequelae of this is what's called long COVID, but it has a more official name now called the post-acute sequela of COVID, or PASC. And basically what it means is that the symptoms of COVID in some form or fashion last beyond 4 weeks after the onset of illness. And this is especially true in people who say were never hospitalized. And sometimes people get better and they think they're out of the woods, and then boom, they get some other manifestation, and these things can wax and wane. So it's a very peculiar syndrome. It's affecting, estimated at a minimum, 10% of the people who have had COVID, at least symptomatic COVID, and some estimations go up to 30%. The problem is, because this is all so new, the actual definition is still being developed. And since there's no real strong operational case definition just yet, CDC and others are having trouble tracking the epidemiology of this. Although there's a major focus at CDC, there's a major focus at NIH, and there's a major focus around the academic institutions in the country and the world, for that matter, that are now beginning to focus very heavily. Why? Because as we bring this epidemic under control, which I hope, we all hope, will happen in the next 3 to 5 months as the vaccine gets more widely available, the concept of PASC, the concept of post-acute sequela of COVID, is going to be with, unfortunately, a fair number of people over a prolonged period of time. So this seminar could not be more timely. There we go. There we go. So this is the United States. I think everybody has seen these graphs. There was a surge, another surge, and then a huge, I would call, triple humped spike that occurred between November and the end of January. And we're coming out of it now, but the reason I show this is that we're talking about well over 25 million people in the United States who have been affected. And of course, we know about the 500,000 people who have died, now probably 520,000, just incomprehensible. But so is the number 25 million. So if we're dealing with something even at 10% of folks who had COVID developing this, that's 2.5 million people in the United States right now who are going to be dealing with this. So we know that COVID, of course, affects the respiratory tract, but if you just let your eyes dance across this slide, you can see that the sequelae basically affect almost every organ system. And this is mostly referring to the acute COVID. So I'd say, in my experience, taking care of a lot of patients with COVID in the outpatient setting, headaches are almost universal. Some degree of fuzzy thinking or fog, brain fog, a lot of people claim. We've seen thromboembolism, liver trouble, kidney trouble. Mostly those are in people who have been admitted to the hospital. We've heard about COVID toe in the dermatologic space, but there's a number of other lesions that we might see. The heart manifestations are not terribly super common, if you will, but we do see, especially in the hospital setting, a number of problems with even acute myocardial infarction or arrhythmias, heart failure, and then something I'll talk about a little bit later called POTS, and we'll go into that a little bit. And then endocrine and GI trouble. Diarrhea is actually pretty common in the acute disease. So this is my only thing that has to do with therapeutics, mostly because therapies for PASC, for the long COVID, really are mostly symptomatically focused, and we haven't found a common final pathway of why this is happening to people, but I think we might get some hints from this slide. So this is the actual course of regular acute COVID. If you focus on the left-hand side, initially after infection, there's a couple of days of virologic ramp up, if you will. Sometimes people, in fact, oftentimes people have no symptoms, but they can be shedding virus. And then the host immune system starts to react, and that's when symptoms develop, the ones that you know about, the headache, perhaps some runny nose, diarrhea early on. And the immune response is mostly innate initially, meaning interferon production. And this starts to bring the virus under control as the adaptive immune response starts kicking in around day 7 to 10. So these first two dotted lines, and a lot of that starts to accelerate what we call the pulmonary phase. It's pretty universal for people who have symptomatic COVID, even if mild, that they're going to have some degree of cough. There can be hypoxemia. As you know, 80% of people with symptomatic disease don't go in the hospital. One of the things that we do know, though, just as a bookmark, is during this viremic phase, before the innate immune response drops off, use of steroids in this phase is really contraindicated because it interferes with that innate immune response, interferes with interferon production, and therefore the virus never gets under control well, and that individual can linger in the acute phase for quite a long time because we messed with Mother Nature a little bit by giving steroids early. So if you're in the clinic and you see somebody come into an acute center and recent onset of symptoms, do not give steroids. The exception will be somebody who's terribly ill and needs to be admitted to the hospital and they're hypoxemic on high flow, then you might consider, but that's a rare situation early in the course. But what I'd like to focus on in the context of today's talk is this right-hand side of the equation, going from stage 2B to stage 3. And this host hyperimmune response is what gets people in trouble in the hospital and causes them to go into profound respiratory syndrome, but along the lines, all these other things, especially renal shutdown, another number of things that we won't talk about too much, like the shock and serious immune response or criteria or sepsis-like pictures. And in that phase, the adaptive immune response is kicking in and all kinds of cytokines are released. It creates a cytokine storm. And then drugs like tocilizumab is something that might be used here for inhibiting IL-6. A cute little line I heard was when you talk about that drug, it's clean up on IL-6. So you can say that if you want to. But we don't know exactly where these specific antibodies work and how they work. We know what they do, but we don't know when they're best employed and what role they may have down the road for long COVID, for PASC. We don't know. We do know that dexamethasone, when used later after days 7, 8, 9, actually can help. So the definition that's working, for example, at CDC right now is illness in people who have either recovered from COVID-19 but still report long-lasting effects of the infection, or have had unusual symptoms that are lasting far longer than would be anticipated. So this is from a colleague who many of you know is at CDC, has worked at Emory some, is John Brooks. And what we're really talking about here is the far right-hand side of the screen where the late sequela, there's been a lot of proposed pathways, but none are proven, and it may not be a single final common pathway. We'd love for that to be the case, because then we can develop therapeutic interventions or preventative interventions, but it doesn't seem to be jumping out at us this much. And mostly they're cardiovascular, pulmonary, neurologic, and out of that also some psychological manifestations, as you can imagine, how just dealing with this every day. It's hard enough to deal with COVID, even if you've never been infected. Just the isolation and the mask wearing and all the stuff we're sacrificing just to keep each other safe. When you have this chronic sequela that goes on and you don't know when it's going to end or if it's going to end, it's very demoralizing. And I think that plays into this, obviously. And there's really no viral test. Usually the virus is long gone by this point in time. And the antibody profile itself doesn't help us. Cytokine profiles are being looked at, but it's not quite worked out just yet. This is probably the slide to remember from this talk. This was pulled out of JAMA. Here's the reference here, but it was talking about post-COVID syndrome. And what I'm showing here are the most common symptoms on the left-hand side in the darker green This is what you typically see with acute COVID, and similar types of syndromes or symptoms are seen in the post or the long-term post-acute sequela. So fatigue and shortness of breath are perhaps the most common, but this weird kind of chest pain, and it's not angina. It's just kind of, it's not even hardly a fullness. Patients just say, I'm uncomfortable in my chest and I can't explain it. For those who have respiratory problems, that goes. People who've lost their taste and smell, that usually comes back. And I wouldn't throw that into the long COVID syndrome too much. But when we get down to the headaches that are profound in some people, and the problem of shortness of breath, and the problem of dyspnea on exertion, and vertigo, and ongoing neurologic problems. I mean, there have been, I've interviewed patients who one person is a computer programmer, very highly functional, could not remember how to put things on a stove, like to boil water. Just was totally disoriented to what day-to-day life activities were. And so this type of thing is like profound encephalopathy for those folks. So we're really looking at a lot of variable presentations, especially with regard to cardiac. But to me, one of the most common problems, especially in long COVID, is something called POTS, which is postural orthostasis and tachycardia syndrome. The way that this would be noticed or complained about by a patient, had several patients with this. They're several weeks, month or 2 or 3 out from their illness, and they go to take a shower and suddenly they just get pre-syncopal. Their heart rate shoots up. They feel very dysphoric. They get dizzy. They have to sit down in the shower, for example, just to get reoriented. And just a little bit of exercise, a little bit of physical activity leads to profound shortness of breath because the heart rate picks up, and it's a dysautonomia of some sort. Why it happens, I don't know, but it is pretty common. It's probably one of the most common cardiac things that I've seen. And then, of course, I've already alluded to neurologic complications. I think this encephalopathy is really the one that's most fearful. Meningoencephalitis, not so much. We don't see much meningitis or anything like that. A sort of a multiple sclerosis type picture, Guillain-Barré or Miller-Fisher variant. Remember, that's the cranial nerve abnormalities. It's not so much a major player here. Seizures can be at play, and this concept of a short-term dementia picture with encephalopathy. But the best, I guess, description that most patients complain of, even when the symptoms neurologically are not severe, is what I would call brain fog. Just can't focus, sit in front of a computer screen and just have trouble. You can sit there for about 5 or 10 minutes and just got to step away because reading is a problem. And the process of thinking through problem solving is just overwhelming at times. So where we are right now is with a bunch of questions for which there are few answers. We need to come up with a firm definition. What exactly is this? It's like, think back for those of you who lived through or studied the original problem with AIDS. Remember, AIDS is a syndrome before there was an etiologic agent, acute immunodeficiency syndrome. So this is a post-acute sequela syndrome of COVID. Let's create case definitions and then start collecting data. Once we collect data, how often is happening to people? How many people? How long does it last? And what types of syndrome is it? What causes it? That's going to be our ticket to establishing something more than symptomatic treatment. Are there risk factors? Are there certain profiles that make somebody more at risk for this? And of course, if we find that, can we prevent it? Are there things that we can do? I feel pretty strongly, as you've just heard, that giving steroids early for acute COVID, I think, can predispose people to this, my opinion, but we really need more answers. I'll finish with this thought that I'm not sure that this notion of a post-infectious disease sequela issue is new. We see this. Probably the most commonly reported in our lifetime that is controversial to a degree is post-Lyme disease. There's clearly what I call a Buffalo-Springfield syndrome, which is there's something happening here. What it is ain't exactly clear. And so people with Lyme disease, well past their acute illness, have neurologic and arthritic and cardiac manifestations that does not appear to be related at all to ongoing Borrelia infection or ongoing replication. So use of antibiotics won't help. But it's almost like there's a cascade of an immune system hyperactivity that becomes an autoimmune process of some sort. And I think that same type of thing, if I were to put a nickel out there on what's going on, literally in broad strokes, I think that's what's happening. So I think I'll close there. I hopefully left enough time for not just our other guest panelists, but also for a discussion. So I'll close.
Thank you, Dr. Seg. I'm sure we're going to have a very vigorous and robust Q&A session. At this point, I'd like to turn it over to Dr. Jeff Siegelman for his experience. Again, Jeff, I want to thank you sincerely for your candor and your sharing your experience with us. Thank you.
Yeah, thanks, Fiaz, for the invitation to be here, and to Dr. Sag for setting this up so clearly. You know, I'm happy to give you what my experience has been, which certainly speaks to a lot of those conditions that Dr. Sag just talked about. So as Dr. Kazi mentioned, I'm an emergency physician. My last shift before I was ill was August 2nd. On the 3rd, I woke up with a low-grade fever and a headache. And that's, it never really got worse than that, thankfully. So that first week and a half, I dealt with typical flu-like symptoms that I expected to resolve fairly quickly. You know, low-grade temps, those headaches, some aches, one night of spiking fevers and chills, but really nothing too bad. I isolated in the basement and did some puzzles, watched some Netflix, and I thought we'd be okay. Now, moving on from that initial illness, though, the headaches never went away. Those low-grade temps stayed with me for about 40 days, and my symptoms transitioned a bit from the aches and chills to palpitations and exertional malaise or fatigue, as Dr. Sag sort of alluded to. And that really has stayed with me until now. To give you the ending up front, you know, I'm happy to say that I'm back to work at least part-time now, about 4 hours a day, having gone through a prolonged period of trial and error to find medicines that work and help me sort of cope with the symptoms, but that's sort of ongoing. So to speak more to the symptoms that really have defined my experience with long COVID, that malaise is really what's kept me sidelined more than anything, and the best way that I can describe that is that my battery gets drained quickly. And talking to other long haulers, that's a similar phrase that you'll hear, that, you know, really I can do anything. I just pay for it later. So in the beginning, in August and September, I'd go for a walk, and if I walked a half hour, I'd be okay. If I walked for a mile, I'd be on the couch for the rest of the day and sometimes into the next day. Just so physically drained from that. Interestingly, cognitive exertion had the same effect. So a couple hours on Zoom or time spent reviewing applications or something would lead to the same physical manifestations, which, you know, as a physician sort of looking in was really interesting, but as a patient was difficult to deal with. The other really predominant symptom for me was palpitations, and while I haven't been diagnosed with POTS per se, a lot of the symptoms that I have sort of fit in with that brand of autonomic dysfunction. So at rest, I would have strong palpitations. They would wake me from sleep, and I'd be up for an hour or more. And this sort of sleep disturbances are really common among long haulers as well. A big meal would also lead to palpitations and headaches and brain fog, and that's also typical for autonomic dysfunction. And the brain fog that Dr. Sag mentioned has certainly been pretty pronounced for me as well. And I think he did a really good job of explaining it. For me, I perceive it as a fullness in the head that does sort of impact my concentration and my ability to focus. And it sets in, again, after long periods of cognitive exertion or too much physical exertion as well. And then, about, I guess, mid-January was when my taste started to return. So I'm about 50% back now. So I say that that's salt in the wound. Obviously that's, it's impactful, more impactful than anyone would predict, alterations in smell and taste, but it's certainly not what's kept me from working and contributing at home. And that's really I think my biggest takeaway from this experience is, as an emergency physician, I'm used to looking for life threats and then sending people to their primary care doctors for everything else. But reflecting on how dramatic an impact this very mild illness has had on my life and my family's life and my coworkers has been pretty eye-opening for me. As I mentioned, I was never hospitalized. I was never critically ill, but I was isolated, for 40 days with this lingering fever that didn't quite meet the CDC recommendations for coming out of isolation. So I had to leave my wife to be effectively a single mom for our two young kids for the latter half of the summer. And that had a big impact on our lives. And certainly, with two young kids, I would like to be out playing soccer and being active with them. And well into the fall, I wasn't able to do that. And while my family has been unbelievably supportive, it's hard for a 7-year-old son to understand what that's like and why dad looks healthy but doesn't feel healthy and can't do what he usually does. It's also, really hard to ask for help, and I think that's in our profession. Certainly, we're used to action and selflessness and sort of going out and doing, and for these months, I've had to be much more passive and dependent on others. And it's difficult watching colleagues like Ziad work almost 40 shifts for me through the summer and the fall that were scheduled and I had to call out of at a time when emergency physicians are stretched way to the limit. And that led to a lot of guilt for me. I think guilt about what my colleagues had to go through, what my wife and my kids were dealing with. And it certainly was a challenge, and speaks to some of the mental health implications of this condition that Dr. Sags mentioned. There's a lot of fallout from this. Another thing that came up is the importance of validation for patients, and again, as an emergency physician, I think I've undervalued how important this is in a setting where we're so used to looking to tests to rule in disease. I had 2 COVID swabs that were negative, maybe based on timing, maybe based on collection, who knows, but I never had a positive COVID swab. And then labs and x-ray that were normal and echo that was normal. And each time I got a normal test back, it led to a lot of self-doubt. And fortunately for me, my primary care physician, my family were all quite supportive and went with the symptoms and not with the tests. But reflecting on this, what I really needed was validation that, even though these tests are normal, your symptoms are real and important and impactful. And and that's a lesson I take now as I return to work. I'm trying to reflect on the impact that the patient's symptoms have, regardless of the testing that we come back with. And finally, I'm quite lucky, right? I was able to safely isolate in my basement, keeping my family safe, which is not a luxury that most of my patients have. I have an employer that used a symptom-based approach for return to work, and that's something a lot of our patients are dealing with too. Is that a negative COVID test or resolution of fever means you got to get back to work, and I certainly wasn't ready to, and I'm glad that Emory was supportive about that. I also haven't had the financial concerns that a lot of my patients have because of Emory's benefits and long-term disability policies that I have. So to circle back to speak to sort of where I am now, gratefully I have a group of physicians that are working to help get me better. And as Dr. Sag mentioned, it's really treating the symptoms. So I have been on a beta blocker to help with the palpitations, which has been quite successful, in addition to compression socks and a pretty rigorous exercise, slowly progressive regimen that's helped with that too, and that comes from what we know about treating POTS patients. I'm on antihistamines, which helped with the brain fog a good bit. Why? I don't know. I don't know that most people do yet, but they've been fairly helpful at quite high doses. And I've dabbled in various supplements, which, it's hard to argue with someone when you're 4 months into COVID, long COVID, and someone says, you got to be on vitamin C and this dose and vitamin D and zinc and mag. And sure, at some point you start taking every bit of advice you can. And in fact, right now, I'm undergoing hyperbaric therapy as a sort of a Hail Mary to help, to hopefully take advantage of its anti-inflammatory effects. So the jury's still out on that. But you'll see this among long haulers that, in the absence of clear guidelines about therapy, we're sort of making our own way. And there's a bunch of support groups where people are advocating for various therapies. And speaking to a group of toxicologists, I think that a lot of that may land in your lap, depending on how appropriate some of those recommendations may be. But it's just a lot is unknown, and we'll see. But I'm hopeful. Back to work 4 hours a day, and so far so good. So maybe I'll pause there, and we can continue the conversation.
Thank you so much, Dr. Siegelman. I'd like to, at this point, invite Dr. Sag to make some comments or ask some questions, and Dr. Kumston as well. Maybe we'll start with Dr. Sag.
Okay, I can't get my video back on, but I think you can hear me. I think that the bottom line is that this is so highly variable, and we frankly don't know what's causing it, and there's no, like I said, common final pathway. But what you heard Dr. Siegelman say is that it is very individualized. I had COVID back in March a year ago, almost exactly to the day, and I had fatigue that lasted for 8 to 12 weeks afterwards. I was functional, but I like that description. My batteries just ran down in the middle of the day, and I just had to lay down, which isn't like me normally, and I've got through it. But it's a strange thing. I wouldn't know to call that post-COVID. It took my body a while to recover. And somebody else in the chat had mentioned about smell. I had lost my smell. And yes, you can retrain. There's ways the ENT folks in particular have approaches where you work with strong substances, lemons or citrics or vinegar or whatever might be safe, and it comes back. I can't say it's 100%. I will say this, that I lost, my hearing took a hit during the acute COVID, and it came back, but it's not normal. So I've gotten hearing aids since then. So this thing is a horrible infectious agent, and we got a lot to learn.
Thank you, Dr. Sag. I agree. I just want to share that my father, who's 88 years old, also had COVID in November, and now he actually lost hearing in one of his ears. And currently he's suffering with this. We're trying to get him evaluated. Dr. Kumston?
Thanks, Dr. Kazi. I just want to thank ACMT again for inviting me here as a guest moderator too. So we have many questions, so we might as well just get started. One of the first ones that popped up was a question about what's, I guess, Dr. Sag's opinion about whether vaccines might help with long COVID, or what role do they play potentially with this?
I don't know. I wouldn't necessarily think that it would. The one thing we do know that the vaccine, at least the antibody response and probably the T cell response to COVID, is much stronger than the native infection. It's really interesting. And it also seems to be more durable. So if somebody's never had COVID, they get a vaccine series, their immunity is better. And so you could say, well, maybe that help with a better immune response will help, but I could also flip it and say we should be monitoring for any signs of long COVID induced by the vaccine. I'm not trying to create fear around the vaccine. We just know so little. So far, there's been 50 million people in the U.S. vaccinated. I'm not hearing anything and no noise about this. There's been actually remarkably few side effects, but I don't know that I can piece together a puzzle that makes sense, a solution that ties vaccine to treatment of long COVID.
Okay. Just looking at here, are you, some of these other questions, are you familiar with a WALS protocol? WAHLS, WALS?
For the
long COVID? Yeah.
No, I'm not.
Someone brought that up. Dr. Siegelman, neither? Okay. Someone is suggesting to Dr. Siegelman, did you try vitamin D or B6 pre-illness?
Pre-illness. No, I was on. I was on nothing pre-illness.
Yeah.
And if I can jump in as well and help Dr. Constant, we can go back and forth to make it a bit more, give us some time to read the questions. Dr. Sag, do you think someone with long COVID should wait before they get vaccinated? And I would ask that question to Jeff as well, if you have been vaccinated, if you don't mind answering that.
Answer is I don't know. I will say that my personal opinion, at least for Pfizer and Moderna, that we will ultimately reduce the change of recommendation to one shot as opposed to two for those vaccines, because the data I've seen so far, and it's accumulating pretty rapidly, is that one shot really gets a tremendous boost for antibody production. And the second shot, moreover, doesn't add anything further. So I would advocate, if people might get one shot, I don't know. I could argue, like I said earlier, it might make things worse, but we just need to collect data, and it'd probably be best if that was done under a study setting. But if it's been more than 6 months since somebody had COVID, I'd be worried, weighing things out, I'd be more worried about picking up COVID again than I would about a problem with the vaccine. So I personally would recommend moving forward, but maybe just one shot if it's Pfizer and Moderna.
Thank you. Back to you, Dr. Constant.
Yeah, I think a really good point that someone brought up was how do antidepressants play a role here as a therapy? Because certainly there are, as already discussed, issues with isolation and that sort of thing, and then plus prolonged symptoms. I guess for either of you, how do you feel about that?
I can only speak to my personal experiences. My cardiologist included bupropion as part of my therapy in the hopes that it would help with the brain fog as functioning as sort of a stimulant. And this, there was some thought about also using things like methylphenidate or other amphetamines to sort of rev things up. We haven't gone that way yet, but I do know a lot of people are on SSRIs as well, and I've heard some postulating about the role of serotonin in some of this, but I can't speak to that.
Well, I'd take us back to Psychiatry 101. And the most important thing is to get a diagnosis right before we move to therapy. So in the case of this situation, we got to separate out demoralization, which almost all of us are going through, and certainly somebody who's got long COVID is going to be experiencing just the frustration of dealing with this in the life circumstances, versus true depression, which has nothing to do with circumstances. It's about the dopaminergic, mesolimbic dopaminergic pathway in the brain that gives us our yes, right? And that's what depression is, when the firing isn't happening right. So an antidepressant is only functioning in the brain. It's not changing life circumstances. So if somebody's demoralized, you don't throw an antidepressant drug at that, if that's all it is. That talk therapy helps. But in the case of an antidepressant, it's used when there's true depression, where you need to help with the neurotransmitters. Now, it could be that COVID interferes with that. And it might be also, as Jeff just said, that there could be an issue where there could be other issues with serotonin pathways that this could help with. But to jump on an antidepressant to raise mood because somebody's demoralized doesn't add up to me.
Thank you, Dr. Sag. Now, Dr. Wax, go ahead, Dr. Wax.
I had a couple questions myself, and I really appreciate this discussion. It's really been great. And keep the comments coming in both the Q&A and the chat. I from reading the chat, a bunch of folks on the webinar are sharing their own experiences, and I really appreciate hearing from people about their experiences, and we'll try to get as many answers as we can. I mean, we're all learning about this all together. But back to Dr. Siegelman, could you just mention again that you actually had 2 PCR tests for COVID which were negative? Is that correct? And then did you ever have any antibody testing to confirm that you had the exposure to the virus?
I did have lots of testing, and I have not had a positive COVID PCR or antibody test, which is frustrating, and certainly can beg the question, was this actually COVID? Don't know. Could have been enterovirus, something else leading to a very similar post-viral syndrome, but Occam's razor, probably it's COVID. And then that begs a different question. Is there some difference in the way that people with long COVID develop antibody responses? And I'm sure Dr. Sag would say, I don't know.
Right.
But I know, Dr. Siegelman, you mentioned to me on one of our conversations before that there is now maybe a group, a social media based group of long COVID patients that communicate amongst each other. Has that been studied, and to look at, for example, how many had positive PCRs, how many had positive antibodies?
Yeah, there are several groups, and sort of each country has its own. So the one that I'm a part of is called Body Politic. It's on Slack, and it's got several thousand members. And they've done some studies of their, some survey-based studies of their membership. About half of that group never tested positive for COVID at all. You got to remember, though, that in that group are many people from the early days of this pandemic, right? March, April, May, when we weren't testing people with mild illness. And so for those of us who had mild illness and then developed long COVID, many of those were never tested or were tested very late. But of that group, 50 or more percent never tested positive.
For the PCR or the antibody, or both?
The survey I saw, I don't think specified.
Very good. And I would ask Dr. Sag here, before I turn it back to Dr. Kumston. Dr. Sag, Dr. Michael Coslet, one of our ACMT members, is asking about any similarities between post-viral fatigue syndrome that accompanies EBV, or Epstein-Barr virus, and PASC. And I'll turn it back to Kirk after that.
Yeah. We've been dealing with that concept of chronic fatigue syndrome for decades, certainly throughout my medical career. And it's hard to pin it down to a specific etiologic agent. A lot of people have proposed that it's post-viral. A lot of people have said Epstein-Barr virus, but that's really hard to prove. In my personal experience, this all aside, when I've been referred people for chronic fatigue syndrome, the number one question I ask is, how are you sleeping? And almost universally, everybody's got poor sleep. And I find that just clinically, if I treat their sleep disorder, sometimes it requires CPAP, whatever, their fatigue gets a whole lot better. And so it might be true in COVID, post-COVID as well, that some of the fatigue may be helped with some sleep hygiene, but I don't think we've ever nailed that down well. And I don't know that there's a common pathway for that.
Definitely, Ziad, the people with chronic fatigue syndrome are lending us what they know about how to treat that. And I know, as I mentioned, a lot of what my treatments have been taken from other chronic conditions. And I think they're hopeful that all the attention on long COVID may have collateral benefit for those communities as well.
Thank you.
But there seems to be unifying questions on here about what about diagnostics for this, for the long syndrome? I mean, clearly we know for the acute effects of COVID and what we need to test for, but is there something that everybody should routinely be doing in these clinics all around the country, in the world?
Well, I can start off and say that pretty uniformly, once people get into the post-acute phase, the PCR test for the virus in the nasopharynx is gone, is negative. So I don't think this is a persistent viral infection that's reproducing. I think we pretty much ruled that out. There have also been there have been some degree of biopsies and pathology studies that have shown that there might be inflammation, but there's no evidence of viral fragments or viral particles. So I don't think it's an ongoing infectious replicating virus that's the cause. But beyond that, I don't know of any specific tests. People are checking a lot of inflammatory markers, and sometimes they're elevated, but they're not wildly elevated as a rule. So then people are using steroids and people are using a number of other approaches, but it's very much shotgun and not terribly well focused on an etiologic pathway because it just isn't known.
Thank
You
you, Dr.
mentioned,
Sag.
You mentioned steroids early as being detrimental. So early with COVID symptoms, and I guess, do you have, say, a time frame when that would be safe to start steroids?
Thank you for asking. So yeah, the time not to use them as a rule is not in the first 7 days after acute onset of symptoms. After that, steroids can be life-saving. The Reprieve study had dexamethasone as the most important factor for keeping people alive after day 8, 9, or 10 or so. And it makes sense. That's why I was really careful in that slide to point out that division between the viremic phase and the hyperimmune system phase. And so anytime after that, say day 7 to 10 of acute illness, then I think steroids can be used effectively and can be life-saving. And then the specific inhibitors of different cytokines, just the data are all over the map. Some show benefit, but I think it's really about, it's got to hit that precise window when and have a certain level of abnormality for it to really be best used.
Now, I'd like to ask you, Dr. Sag, because I know you've been on national panels, and of course, your career in research is well known. Do you see that the current criteria for using dexamethasone is restrictive? Should it be expanded a little bit beyond those 7 days, but to patients that may or may not require oxygen, for example? I know some people that asked about even prednisone if they have COVID 8 days out to prevent some of these sequelae. That's my first question. The second question that's in the chat is about about national efforts to formalize the data collection, for case definition, the data collection, the clinical trials, all of that. Are you aware of what's being done at the national or international level? Thank you.
Sure. So the first point, steroids, again, after the first 7 days, and I wanted to be precise about what happens early is that innate immune response with interferon. You don't want to mess with that. You want that to play out. Once that's over and the adaptive immune response is kicking in, then if it's becoming especially problematic and symptoms are progressing, that's when you might pull the trigger. Now, for sure, when people become hypoxemic, almost every doc I know uses steroids, as they should, in my opinion. But before that, I'm seeing a lot of people in the acute respiratory clinic here at UAB, and they're coming in at day 8, 9, 10, and they're slightly, well, they have let's say, an oxygen sat level of 92. They don't need to be in the hospital, but I might use steroids in, especially if their chest x-ray is abnormal and they're struggling, and it usually does help. It's a short course, it's a burst and a rapid taper. The actual dosing is different as any one of us, actually. But the concept is there. Regarding the National Registry, yes, there's now an RFA out from NIAID, along with a lot of other institutes, that's looking to pull together a team nationally of academic sites that will collect data just like you described for this exact purpose, to see if we can normalize what to do. Remember, we're only a year into this. And when you pull back and you go, we already have a vaccine, are you kidding me? That's amazing. When you look at AIDS that went from a definition to a virus in 2 years, 3 years, and then the test wasn't even available until 2 years after that. So we're light years ahead of where most things are, but we still have a long way to go.
There was a question about, I guess, how do you clear somebody? And maybe that's a good question for both of you. Like, when would a physician tell their patient they're cleared to go back to work, or, I mean, what sort of occupational restrictions and that kind of thing would you recommend?
Sure.
Well, the CDC is more or less straightforward about this, right? So for the acute illness, we know that it's 10 days plus 24 hours fever-free and resolving symptoms, and that's sort of what kept me in the basement. But if your question is about long haulers per se, I'd say again that I'm fortunate that my physician was quite supportive and was able to sort of talk through the symptoms with me and sort of how does it impact my ability to function in day-to-day life in the context of what my day job is, right? So trying to be an emergency physician is different than some other jobs that I've held in my life, and has a different standard for when I can return to work, I'd say. And so that definitely needs to be individualized, just like it would be for any other illness, I'd say.
Yeah, I would agree. It's really about function, and it depends on what the job is, but the person has to be at a point where they can literally function in their job, and then they can go back. But I think we need to keep an eye on the fact that these things can wax and wane, and it may be that they get taken back out of work because of a recrudescence of symptoms.
Dr. Siegelman, can you maybe share a little bit about the job-related issues that I think you described that to me, and I know we're fortunate at Emory to have this environment, but I know you've learned a lot. You said to me that you've learned a lot from this experience, from an occupational disability insurance type thing. Do you mind sharing just a little bit about that?
Sure. Yeah, I've learned a lot about HR and medications and disability insurance and all kinds of stuff. But really, we are very fortunate at Emory. I had 6 months paid salary continuance, which is unheard of in almost any industry. So that was wonderful. One thing I learned, as I discussed with HR about going on to FMLA leave, that I asked them, can I still do a couple hours of office work a day? It's actually keeping me connected. I can accomplish things, and it gives me some purpose to the day that's not Netflix. And there was actually a mechanism for not being totally on leave, but rather working 4 hours a day just on office work from home. I think they called it intermittent leave, and that effectively doubled my FMLA time because I was really off half time, and also more importantly, let me still contribute to the work, at least in the residency that I participate in, and some other committee work at the medical school that I do. I'm definitely grateful that I've had a long-term disability policy that I purchased individually when I graduated residency, and I've paid for it for the last 10 years, and now I'm benefiting from it. And also that there's a separate policy at Emory that's helpful. So even now in my 7th month, as that initial short-term benefit lapsed, I'm still whole. And Emory's policy even still continues the school's contribution to my retirement fund, which is, again, I feel quite fortunate about that.
Thank you.
I have a question for Dr. Sag, a little bit off topic, but I know you're very much involved with vaccinations as well, and there have been a number of questions in the queue about this. So now that more and more people are getting both of their vaccine shots, the question is returning to normal or continuing to take precautions. I mean, what has generally your advice been at this point?
Yeah, it's a very timely topic. The thing that pops in my head is the play from the 2000s called Next to Normal. So I think we're going next to normal. We're not quite back at normal. So let me be precise. If I have been vaccinated fully, and I have 4 friends who want to get together and they've been vaccinated fully, then we can get together. We don't have to wear masks. We can be normal in a sense, as long as there's not somebody in the group who hasn't been vaccinated. That said, if we're ever in a situation, or when we're in situations where even though we're vaccinated, there are people around us who aren't, we still should be wearing masks, because there is this possibility, in fact, likelihood, that we could be transiently infected, be asymptomatic, but shed virus, not for a long period of time, but for some period of time, and we inadvertently could infect them. So for this transition period from now to, let's say, the first part of the fall, I think we're going to be in that situation. So it's really courtesy to wear a mask, and not to make any kind of other statement except to say, I don't understand what Mississippi and Texas are doing right now. We're finishing this experience, and suddenly they're just saying, okay, we won and we don't need masks anymore. I don't understand that, because there's no scientific or public policy reason to do it. I suspect it's other things like politics, but that we don't want to do that in our society, right? So we want to continue using masks and being out, but it's really kind of common sense, isn't it? If we've been vaccinated and people around us have been vaccinated, sure, we can get together.
Great, thank you. And just one follow-up about the transmissibility despite the vaccination. It's my understanding with the J&J vaccine that there's some early data that may actually prevent transmissibility, but they haven't been able to say the same thing regarding the Moderna and the Pfizer. Any reason why there may be some differences?
Yeah, there's a great reason, because the Pfizer and Moderna vaccines, remember, we didn't know if it was going to work. So they were focused on the development of symptomatic infection, period. And it showed 95% efficacy, through the roof, unbelievable, right? But they didn't test for asymptomatic. The J&J did. They had a screen, not of the whole population, but a subpopulation, and they noticed that the people in the vaccine group had less numbers of people who had asymptomatic infection. And so therefore they're saying that translates into, of course, less transmissibility. There's a study out of Israel where they have vaccinated a good portion of their population, and they have demonstrated some degree of decreased transmissibility. They've used mostly Moderna, some Pfizer. So yeah, so it just makes sense, right? So just to cut to the chase, when we have a vaccine on board and our immune system is primed to fight the virus if it comes into contact, it will quite effectively, quite quickly, and it will reduce the amount of viral load in our nasopharynx and therefore reduce our ability to transmit. But it probably, I can almost say certainly, it won't take it to zero. So once everybody gets vaccinated, then we're platinum, right? But as we move towards that, I think we should just assume that there's a possibility that we could transmit to others.
And one additional vaccine question is, again, interpretation of it's 95% protective. So for the other 5%, does that mean that they're protected against severe disease, or maybe not?
No, they are. They're 100%. So to go through the data for all three, the 95% or the 73%, whatever the number is, that's against any symptoms of COVID, right? And then among those people who did become symptomatic, almost all of them were mild infections. But in each of the studies, even if there was a severe case, which simply means O2 sat 94% or less, that's all, there were 0 hospitalizations and 0 deaths due to COVID in all 3 studies. And these are tens of thousands of people. So yes, it prevents symptomatic infection to a large degree and prevents what we really fear the most, hospitalization and death. So they work like gangbusters, much better than the flu vaccine and probably better than the shingles vaccine at the end of the day.
Do you think that's going to change your opinion will change with the mutant
Yeah. So the mutants,
variants?
right. So the mutants, most of them are still inhibited by the antibody produced, maybe not to the same degree. J&J had a site or 2 or 3 in South Africa, where the South African variant is, and their protection rate, as the United States was 73%, they were in the high 50s. They were 57, 58%, but it was effective still. And they didn't have hospitalizations or death, even in South Africa. So it works. Will there be a variant that emerges that's going to be resistant to all the vaccines? Maybe. If we wear our mask and do all the other things, maybe we'll prevent that. But if it does, Pfizer, Moderna, J&J, others have already created booster vaccines that they're now starting to test. So they'll be ready for us, and there'll be enough supply because we have time to build it up if and when that time happens.
Thank you.
Thank you. Ziad, any last questions you think?
I want to just add one more question and then turn it over to Kirk for maybe final questions. Regarding the therapy that is being offered in your clinic, Dr. Sag, or Dr. Siegelman, that was offered to you. At what point do you try to think about cognitive-based therapies? And is there usually a part of this an evaluation by psychiatrists as well?
Well, I can tell you what we do, and it works extraordinarily well, is if somebody has recent onset of symptoms in the last 5 days, 7 days, they're older or they're at high risk for hospitalization, we give them monoclonal antibody. It works like gangbusters. Over the last 8 weeks, we've treated well over about 750 people. We've only had 15 admissions. That's from high-risk people. Yeah. So it works, but you got to get them tested soon after the onset of symptoms, and you got to get them in. So the take-home point to the community is monitor yourself for symptoms. Don't go into denial, even if you've been vaccinated. If you have symptoms that are suggestive of COVID, get tested. And if you test positive, get in and get the monoclonal antibody. As far as psychiatry, we aren't doing that routinely, but I think it goes back to other indications. Dr. Siegelman, what do you think?
Yeah, I think, again, individualized based on the specific symptoms the person is having. You know, I reached out on my own to my psychotherapist that we've used before for support during isolation, and you know, some patients will have that insight. Some, hopefully, many will, but I think again, it's just individualized to what people need.
Yeah, and I think, you know, thank you, Dr. Siegelman. Going back to the monoclonal antibodies, I think, we had a recent webinar on that topic and invite our viewers to consider watching the recording. It was very informative. Again, thanks for both of you on my behalf, and I'll turn it back to Kirk, Dr. Constant.
Well, thank you. How much more time do we want to go?
Other question? Yeah.
All right. Well, a common question that appears here is about people that already have, say, chronic Lyme, or a previous viral infection, or chronic fatigue, or let's say even POTS from our for another reason. Like, do you see, how, the long, COVID long syndrome, how that affects them differently or the same? Can you comment on that?
I don't have any insight. I mean, I think it's a good question, and maybe we'll hopefully we'll learn about it over the next year. But I mean, instinct for all of us would say, first off, it's tough to have those other syndromes or disabilities in the first place, and I don't see how long COVID could help that. So could there be additivity? Sure. But I can't comment any further than that.
Another question was, any specific recommendations for the dysautonomia from POTS for these patients?
Yeah, I think Dr. Siegelman alluded to some. Beta blockers are used kind of often. The antihistamines I've heard about. I'm not an expert on that topic, but it's a tough thing to treat. It's all about symptoms. The underlying causes, when it does happen outside of COVID, isn't known, but it can be quite debilitating. And I know people who are marathon runners who can hardly walk from their house to their mailbox without getting short of breath because of tachycardia and hypotension. It's awful.
Okay, and I have two final questions. One is a question from someone who has been working in a long-term care facility, and they see these patients come in, months out from their COVID who, eventually die, and they're still kind of in COVID recovery. And I guess, some of the issues are regarding, the cause of death and whether the long COVID itself may actually be the, precipitant to cause their death or not. Any comment about that?
Well, I'll just comment in general,
Yeah.
especially in the older populations. It's pretty common for people who end up dying that they get in the hospital, they recover, they get sent out for, let's say, rehab, and by then they're not infectious and and then like at day 30, they get readmitted with what looks like a recrudescence of symptoms and they die. What is that? It's probably not the virus coming back. It's something else. So could that be a long COVID variant? Wrong word. Could that be a long COVID sequela that's happening? I don't know. But that story is pretty darn common, enough to catch your attention. When you get into cause of death issues, holy smokes. I mean, it's to me, it's like I use the legal term, but for COVID, would that person have died? Everyone's going to die of a cardiopulmonary arrest, right? But what is the true cause? That's hard to discern sometimes.
With the another actually interesting question with the use now of the monoclonal antibodies, have you seen any patients that actually got the monoclonal antibodies but then developed symptoms consistent with long COVID?
I haven't at this point, and maybe that's telling us something, but it's still a little bit too soon because monoclonal antibodies really didn't come out until November, December early, and not into widespread use until late December, early January. So it's a little bit too early to say. Need to watch for it.
Okay. And the last question is just getting back to vaccines again, with the concern still about the genetic, variants, does that impact at all your masking recommendations or not, particularly if you've already had the vaccines? Should you still be worried with other people that have had the vaccines about, the potential of getting one of these variants?
Yeah, I'm not too worried about what I said earlier, getting together, but I think the question is well founded in this regard, that where these mutations occur that lead to, for example, the UK variant, where it is truly more infectious, where the mutation occurs on the spike protein is in the receptor binding domain, which makes it have more affinity for binding. Makes sense, right? So that if we're exposed, there's more likelihood that it'll come in and stick and then set up an infection than the original wild type. Could that put us more at risk if somebody in our close-knit group who've all been vaccinated is shedding? Maybe, but it's a relative risk, right? It's a probability thing. And so I still think we can get back to next to normal in that situation. But I think for the rest of the people in the world around us who have not been vaccinated, be a good citizen, and wear a mask till we get out of this.
Are you flying again?
Am I? Not yet. Not yet, but I would. I mean, some airlines, like the one in your city, is remarkably good at spacing people out. Some other airlines are still packing people in like sardines. I think that's wrong, my opinion. But yes, I would fly right now, and wear a mask and do all the other precautions because I've been vaccinated.
Well, I'd like to thank again Dr. Sag and Dr. Siegelman for just really an outstanding presentation, and much appreciation to Dr. Kumston and Dr. Kazi. It was really very rewarding to get all these comments in the chat box and the Q&A, and please do provide feedback to us. There'll be an evaluation question, or you can contact us at info@acmt.net. But I just think it's very comforting to have this kind of communal discussion. And again, I'd just like to thank everyone for this. Dia, if you could just go to the last 2 slides, please. So we're going to continue these webinars over the next several weeks. Have a couple outstanding webinars coming up as well. Next Wednesday, we're going to be discussing COVID vaccine distribution, designing an effective and efficient system for distributing COVID-19 vaccines. And we have several academic researchers who really are leaders in this work who will be presenting next Wednesday. And then the following Wednesday, we're going to be looking at some of the issues with long-term care journeys, long-term care facilities, and what they have learned over the last year, and how they're preparing for the future. So that should be really a wonderful presentation, as well as an update from the front lines of Israel. We've periodically had updates from the front lines, and Israel's now vaccinated a good portion of their population, and we're very interested to hear about their experience. So please join us for these upcoming webinars. The entire webinar series can be found on our website and also online in our prospectus. Feel free to continue to suggest future webinar topics. Again, thanks again to the presenters and the audience for participating.